Good afternoon, everyone, and welcome to this afternoon's Jean Monnet Centre of Excellence seminar. My name is Dr. Catherine Simpson, and I'm the Deputy Director of the Jean Monnet Centre of Excellence. And I'm delighted to have my colleague, the Director of the Jean Monnet Centre of Excellence, Demetrius Papadimitriou, here with us this afternoon as well. This is our first seminar of the new year, so welcome to everyone. It's lovely to have so many of you here, and hopefully these events will resume to be face-to-face in the not too distant future as we slowly get towards the end. I say that with trepidation of the current as I say, climate, the current COVID situation we have. I'm absolutely thrilled to welcome today Dr. Eleanor Brooks, who is going to be talking on the topic of COVID-19 and EU health policy. And I think it's really telling kind of how far we have come in the last couple of years about how this is maybe now a topic that we would maybe have not discussed as at length, but now kind of is very much on our radar. So I'm really, really delighted to welcome Dr. Brooks with us today. Eleanor is a lecturer in health policy at the Global Health Policy Unit at the School of Social and Political Science at the University of Edinburgh. She holds a very prestigious UKRI Future Leaders Fellowship, supporting the better regulation for better health. And this project explores the impact of the EU's regulatory reform processes, the better regulation agenda on health policy. Broadly speaking, Dr. Brooks researches in the area of global health governance, policy tools in health governance, European public health policy, and the Europeanisation of European Union public policy as well. Dr. Brooks is also a scientific advisor to the European Public Health Alliance and coordinator of the UAC's research network on EU health governance. And I really couldn't think of anyone better to discuss the topic of COVID-19 and EU health policy with us today. So I'm going to hand over to Eleanor, and she's going to talk for about half an hour, and then we'll have a great opportunity for questions and answers at the end. So again, you can raise your hand or you can use the chat function on the right-hand side of your screen, and you can wait till the end, or you can populate that throughout when things come to you. So I'll hand over to Eleanor. Eleanor.
All right, thank you so much, Catherine. Thanks for that kind introduction, and thanks to the Jean Monnet team at Manchester for the invitation. I'm really happy to be here. I'm going to present essentially the outline of a report, or my contribution to a report called State of the EU in 2022, which is a collaboration between UACs and the UK in a Changing Europe initiative. And that report's due for publication in May. So what I'll present today is just part of what I'll be my small contribution to that report, which is broadly speaking about the EU's health policy, but I'm going to focus in particular on the European Health Union, which is a particular package of initiatives, but I'll speak a bit about how that fits into the EU's wider health policy, and where I think it might contribute to sort of changing directions, if you like, for the EU health policy more generally towards the end. So I'll start with the Health Union itself. So in terms of what the Health Union is, it was a package of initiatives that were introduced in November of 2020. And the Health Union is, I suppose we would say, the core response to the EU's COVID experience. So November 2020 being a little bit after the sort of initial few months of the pandemic and that emergency crisis response period, the EHU is what's come about after some time has been taken to reflect upon the strengths and weaknesses of what the EU was able to do in its response in those early months. So it's a bit more of a considered response rather than an emergency response, if you like. The contents of that package then are just included in the first 4 bullet points here. So the first 2 sets of initiatives refer to agencies that the EU already had. So the European Centre for Disease Prevention and Control and the European Medicines Agency. Those are the 2 key agencies that were involved in the EU's COVID response, sort of in the early months, if you like. You'll see at the end of each of those bullet points that these packages are at different stages of negotiation. So the package or the piece of legislation to extend the mandate of the EMA, that's already been adopted, whereas the regulation for the ECDC, that's still under discussion. It's expected to be adopted in March. So there are just a note, there are some different processes, some still in play and some already adopted. For the first 2, what these regulations do is extend mandates. So they take agencies that already existed and they extend what they do, extend the tasks that they're involved in, they increase the resources available to them, increase the capacity that they have to fulfill their responsibilities. So for the ECDC in particular, how we might characterise the extension of tasks that's happening there. Up until this point, the ECDC's remit has been very squarely in risk assessment. So collecting data where it can, looking out for threats where it can, and assessing the risk that it sees off the back of that data that's been given to it by the member states. What the regulation does is extend that mandate into risk management. So that means extending it into areas where it's able to advise on what member states should do in response to that risk assessment. So previously, the ECDC did the assessment and it was up to member states to decide how to respond to that and to manage that risk. So this is quite a crucial extension of mandate, moving it much more into a sort of governance of risk area rather than simply assessment of risk. And there are a number of tools that it's been given to fulfill that. So there's an increased budget, various increased capacities along the way. It will have an EU task force, which will enable it to put boots on the ground in response to health emergencies, which it's never been able to do before. So teams of health professionals and public health professionals that will be able to go into emergency situations and assist directly. It will also have a role in assisting member states to draw up plans for national preparedness and response. So this increased focus on preparedness and response is contained within the cross-border health threats decision, which I'll discuss in a second, but the EC has an integral role there in advising member states on those plans, and it will be given the right for the first time to issue recommendations to member states about how they should organise preparedness and response, whether their plans look robust enough or efficient enough, and whether they're covering the right areas. So we see an extension of tasks, also some slight changes to governance structures and introduction of new governance structures, all moving in an integrative supranational direction. Similarly with the EMA, we see extension of tasks again, but with the EMA, the difference is that these things are confined to emergency situations. So the ECDC, these extension of tasks apply at all times. For the EMA, the extension that's being proposed is for emergency situations only, and I'll come on to how those emergency situations are going to be defined. But with the EMA, we are focusing very much on what will happen if a public health emergency is declared. So the specific task that's being extended here is into what we're calling mitigation and monitoring of shortages. So the EMA will now take on a role in keeping an eye on and then trying to address shortages that appear in medicines and medical devices. And these are new roles for the EMA. These aren't things that the EMA has done before. So again, it has an increased budget and various other increased resources and capacities to support it to do this. Again, some new governance structures and sort of organisations within the EMA that will guide that process. Within the EMA set of structures as they stand, it looks like there will be a slightly larger role for member states than against the ECDC, but the ECDC proposal is still going through, so that may well change. But for now, the EMA, it looks like member states have asserted a fair level of control. So the Health Crisis Board, for instance, will be made up by member states and chaired by the Commission, but member states have inserted a discussion provision before the Commission's able to act. It will need to take anything to the Health Crisis Board. So we see some sort of minor tussling, I would describe it as, in terms of a supranational intergovernmental balance within the EMA, and overall the main restriction there is that this will stay focused to crisis situations. How those crisis situations are defined will be determined within the cross-border health threats decision. So we had a cross-border health threats decision before, and that was the main security framework under which the EU's general health security structures were defined, by which I mean the structures that were in place when COVID hit. This is a revision of that decision to try and directly address the shortcomings that were identified during the COVID experience. So this covers a whole range of things. In terms of what it does, it focuses very squarely on and tries to increase the EU's role in preparedness and prevention. And then there's a sort of second thread there on response as well. So it brings into play this idea of national plans, and we see this in many other areas of EU policy. We're now going to also have it in preparedness, emergency preparedness and response, where member states will draw up plans for how they are investing in and contributing to preparedness, how ready they will be, what they have in place should another public health emergency strike. And the EU is going to take a role in coordinating that process, so in receiving those plans, passing comments on them. This is where the ECDC's role comes in, and it will make recommendations and provide advice on those plans, and the EU will coordinate that whole process access in a very similar way that it does in other areas. What I think is worth raising about the health threats decision is it does two other critical things. One is that it establishes a set of indicators of health systems that it proposes states will hand over to, deliver to, communicate to the EU level. And the reason that's critical in terms of where the EU health policy goes from here is that we didn't used to do that. Health systems data is very sensitive at the national level. We're talking about things like the number of hospital beds that are available, the number of health professionals in a given region, how prepared a health system is to respond to an emergency. And that's all quite sensitive data, and it's data that has been transmitted to the EU level before, but never in quite such a systematically required way. So there are some certain sensitivities here that I'll come on to a bit later about where I think this might be going in future. So that's one set of things that it does. It will allow, if it is properly implemented, the EU to establish a body of data on how prepared member states are in their own public health systems and their healthcare systems. The second thing it really strengthens the EU's potential for intervention in a health emergency. So it will allow the EU to declare a public health emergency, which for anyone who's familiar with the WHO's role in declaring public health emergencies is quite a big political role and responsibility, and it has some very tangible political ramifications once it's enacted. That declaration of an emergency is what will then trigger the European Medicines Agency to be able to do all of the new things that it's been allowed to do, and it will trigger some other provisions that I'll come on to in the second regulation in a second. And it allows the EU essentially to take on a role when that emergency is declared in developing medicines, in procuring medicines, really crucially, which I'll talk about a bit more in a second, and in stockpiling them to make sure that they're available for emergency use where needed. So that's a sort of, the cross-border health threats decision is the sort of overarching framework that defines the EU's broad health security framework, and then sort of sets out how the new roles for the ECD and the EMA will work within that. It also talks a lot about the HERA, which some people may have come across or seen. So we have a new Health Emergency Preparedness and Response Authority at the EU level. This is the authority that was supposed to be based on the US equivalent, it's BARDA, which is Biomedical Advanced Research and Development something. I forget what the acronym stands for. It's their Advanced Emergency Preparedness Authority in the US, and the HERA was meant to be an EU equivalent of that. Again, this is established already because of its strange legal status, which I'll come on to in a second, but it has ended up being a little bit weaker, is my perception, than the BARDA is. It's not quite a direct reflection in the way that was initially intended. Nonetheless, it is in place. It's been established by the Commission as an internal Commission service and not a standalone agency. So it's not an agency in the sense that the ECDC and the EMA are. And it's a slightly odd, there are no other real examples, certainly not to my knowledge, of similar services that have been established within the Commission. So its legal position is a strange one, presumably a result of sensitivities and speed, being able to simply adopt that in a Commission decision instead of having to put it through the full legislative process. So it was established very simply by the Commission in September of 2021. Where it has got a legislative angle is with this Council regulation on the emergency framework for medical countermeasures, which simply means the framework that governs how we procure things like vaccines and other medicines that we need in an emergency. That has a political agreement in place, and we're expecting that to be finalised in the coming months within the Council. And what that will flesh out essentially, or give implementation to, is this set of rules around, or set of new frameworks around joint procurement of medicines in the event of a crisis. So the regulation will put in place the rules around the Commission being able to launch into drawing up contracts with vaccine producers, securing those contracts with vaccine producers, organising the distribution of vaccines and other medicines across the EU. All of that will now be regulated under this regulation, and that obviously feeds in to the HERA as well. So within those two sort of sets of the one non-legislative initiative and the one legislative initiative, you have this sort of all-encompassing preparedness and response system, which will organise what happens in the event that a public health emergency is declared. The HERA will operate under two different logics. So for the most of the time, it will be in its preparedness logic, where it stockpiles things and it puts the necessary expertise and capacities in place to be able to launch into action when there's a crisis. And then it has a crisis facing logic, which is when it starts to put into place these contracts and utilising that expertise and the structures that have been organised in the meantime. So those 4 or 5 things, depending on how you count them, make up the Health Union package that was announced in November 2020. It's worth mentioning, though, that those are supported by 2 other sets of legislative initiatives that were adopted slightly earlier, so in March and in May of last year. Respectively, we had the EU for Health programme and the new Union Civil Protection Mechanism. The EU for Health programme essentially is just the EU's large health budget and set of priorities. So that was initially due before the pandemic, to be scrapped. So we had 3 health programmes up until 2020, and the idea was that under the next multi-annual financial framework, we weren't going to have a health programme anymore. It was going to be absorbed into the European Social Fund. There was going to be no ring-fenced standalone health programme within the EU at all. That decision, for fairly obvious reasons, was reversed when the pandemic hit. We now have a standalone fourth health programme, and its budget is 10 times what it was the previous year. It's a whacking great budget of over 5 billion euros, which is pretty unprecedented for health in the EU, and terribly exciting for anyone working in or studying health in the EU to suddenly have all of these resources. So that came into action in March. It feeds into and supports the Health Union. The 2 things are very clearly connected for obvious reasons, but it's much wider because it's not just about emergency response. It's about all of the EU's other health priorities. So cancer, antimicrobial resistance, vaccine hesitancy, which was a priority prior to the pandemic, but obviously is even more of a priority now. All of these things are included under the health programme. It also then links out to the Green Deal and Farm to Fork and all of these other strategies that the EU has going on that tie into health. And it's worth just mentioning the civil protection mechanism. This isn't part of health policy, but because of the emergency preparedness angle, it's obviously very closely connected. So again, the civil protection mechanism was upgraded in May of last year, and that was to include a medical stockpile, for instance, which we didn't have before. The civil protection mechanism had stockpiles, but not of medical equipment because they weren't included under what the civil protection mechanism was designed to deal with. It was mostly about natural disasters, and for whatever reason there wasn't a medical component to that. That's been changed. Again, higher budget, again, increased capacities to deploy experts and professionals where they're needed, and linking into the EU Health Task Force that's under the management of the Centre for Disease Prevention and Control. So all of those things tie together, I think, really nicely to give what's clearly an integrative set of measures that increases cooperation on health at the EU level, dramatically increased financial resources, marginally increased governance structures, I would say, but we'll go on to that a little bit. In all, a really unprecedented and positive-looking step forward for health in the EU. But I'll talk a little bit about how we got to this point, and how these things have come about as a result of the weaknesses that we saw in the initial pandemic response and some of the patchiness in what was an otherwise better response as time wore on, but also a bit about how the nature of health as an EU portfolio had led us to the point that we were at when the pandemic hit in the first place. So just to turn to pre-pandemic health policy then, where we were before all of this started. This was an area where member states had done a very good job over many years and many treaty revisions to keep as much control as possible and to continue putting fences around what the EU was able to do. So we have a mandate in the treaties for health, but it's partial and it's weak. It applies only to public health as far as the EU's exclusive competence is concerned. So we have a very clearly delimited set of areas where the EU can act within health, and those include things like blood, tissues and cells that are for transfusion and transplantation. It regulates quality and safety there. It includes pharmaceuticals, as we know, various aspects of veterinary medicine and products, also medical devices, a really specific, clear and quite short list of public health areas where the EU regulates quality and safety. But it makes, and the member states have always made, a very clear distinction between public health, so those areas that I've just mentioned, and health care, which is about treatment at the individual level. So that's about hospitals, it's about spending on medicines, it's about access to services. All of those things where we as individuals interact with our health service, those remain very clearly national responsibilities. The treaties have, the treaty article on health has 7 parts, and the first 6 very carefully word out what the EU can and can't do. The 7th paragraph is a great big no trespassing sign that says everything else is the responsibility of member states, and the EU should not have any influence over the organisation and financing of healthcare. So there's a really clear set of responsibilities that fragment along this distinction between public health and healthcare what the EU can do. Where the member states failed, or at least failed to anticipate how that would work in practice, is that you can't keep the market out of health in a union based on 4 freedoms. So whilst there is this very clear statement of what the EU can and can't do, there's also a set of underpinning freedoms that completely override all of that. So where pharmaceuticals are traded on a market, where health professionals can live and work in different countries, where all of these things happen, there's no way really to keep a union out of health. And what that means is that, as I mentioned, under the sort of governance implications, actually the areas where the EU has the greatest impact on health don't fall within health policy at all. They fall within trade policy and competition policy and industrial policy and labour market policy and all of these other areas that we know from the broader public health literature shape health, determine health. Some would argue even more so than your access to the health sector, in fact, because they're the things that determine how healthy you were at the point that you got sick. All of those areas are outside of that treaty article, and therefore the member states have struggled to restrict the EU's influence in that way. I would also flag fiscal and economic governance here as an area outside of the health sector, or indeed that would seem not really relevant to health at all, but that completely shape all of those determinants of health, where we govern and the EU governs what governments can spend, where they can invest, how much money they can spend in a given sector, whether they encourage privatisation or the role of private insurance companies, for instance, where they encourage the use of generic medicines instead of on-patent medicines. All of these things that we see every year included within the fiscal governance recommendations also shape health systems. And that's perhaps the most growing and the most difficult to anticipate area of EU governance over health, is how it uses the European semester, the main cycle within which it governs fiscal policy, to inadvertently, sometimes very advertently and deliberately shape health systems and health sectors and national government spending. In terms of parameters, whether I would say all of that led to a situation of political stagnation under the Juncker Commission. The Juncker Commission the commission that was in place up until 2019, did not prioritise health, but we went through a real lacuna of health where there were next to no legislative initiatives. There were really no health priorities within that commission. The Juncker Commission had 10 priority projects. Health didn't feature anywhere within them. It introduced a huge set of vice presidents and new governance structures. There was nothing dedicated to health within those structures. So we went through a really difficult period for health actors and health advocates within the EU under that commission. When the white paper on the future of Europe came out in 2017, the only place that health was mentioned was under the scenario where the EU would do less, and health was one of the areas where the EU would stop acting almost entirely because it was deemed to be an area of limited added value, and that was the only place it featured in that commission's vision for the future of the union. So we went through some really concerning times for health advocates during that period. Things were starting to look better by the time Ursula von der Leyen had come in. She had a much more ambitious, this might be a big word, but there was certainly a visible and a present health agenda and some more clearly defined objectives there. And then obviously COVID has thrown that into quite sharp relief. But there's certainly a sense at the point at which COVID hit that the health agenda was starting to recover from a really difficult few years. So in terms of what that sort of implies, as I've sort of been mentioning as I've gone along, we have some direct public health regulation, but the funding for health has been very limited, and the legislation on health has been limited to these very direct areas where the treaty base permits. Disease prevention and health promotion and the social determinants of health and all these public health areas where you're able to improve the health of a community before the point where they get ill, the EU was weak on that because that's not where the treaty base lay. The funding for that was limited, the legal mandate for that was limited. We did much better in the areas that were connected to the market, and that's where the EU had the greatest impact. And I've written little bits elsewhere about what that does to policy making in that scenario. So the ceiling that puts on entrepreneurship in a scenario where you have a commission that is not enthusiastic about health policy in an area that was traditionally driven by policy entrepreneurs having to find the little spaces where they could use the market to achieve something in tobacco control, for instance, or use the market to achieve something in alcohol marketing. If you can't do that because you have this sort of political ceiling above what you're able to do, you really see a slowdown in initiatives. So that's where the policy situation was when COVID hit, sort of towards the end of beginning of 2020. And I'll go on just to have a look at the response that the EU put forward to COVID. So what I imagine most people will have seen, and certainly what was being projected at the beginning of the crisis, was disarray and disintegration. So member states blocking the export of PPE, blocking the export of medicines, stopping people from crossing borders with no coordination, a general lack of solidarity, not responding to requests for assistance from neighbouring member states. It didn't look good for the first, certainly few weeks, arguably couple of months, but that turned around pretty quickly, I would argue. The Commission did a good job of reinforcing the four freedoms and its role in defending the four freedoms and threatening or bringing infringement proceedings where states were blocking exports and trading goods. From an internal market point of view, we saw changes in state aid and competition to allow member states to support health systems in a way that would otherwise have been problematic. We saw, for instance, the suspension of the medical devices regulation, so that was due to come into force, I think, in May, which would have had companies focusing on how to comply with new regulations. That was suspended and the date was pushed back to allow them to do what they needed to do and produce what they needed to produce to contribute to the COVID response. We also saw a redefinition of public health at the EU level, which was done very quietly in the footnote of a communication, but would have and will have, if and when it makes it sort of into an immediate policy debate or even in front of the court, a huge implication for what health is at the EU level. At the moment, it's defined and has always been defined as an exception to trade rules. So you can request to be exempt from the free movement rules if there is a threat to public health in your country. The Commission has redefined that to mean it has to be a threat to public health at the European level, a threat to everybody in Europe's public health and not just national public health, which would be a fundamental shift in the way we approach health at European level. At the moment, it remains just a redefinition. It has not been tested, but when that comes around, that will be something with real implications. At the level of fiscal governance, we saw a suspension of the Stability and Growth Pact. I'm not going to go into all of these parts of fiscal governance because we just don't have the time, but the rules around what governments can and can't spend was suspended because it's obviously unreasonable to expect governments to adhere to those rules while they're trying to rescue economies and fight a pandemic. Those rules that, the SGP still hasn't been brought back into play fully, but what the EU was able to do was allow governments latitude to spend money, and the adoption of the Recovery and Resilience Facility, which has made unprecedented sums of money available for spending on, among other things, health systems. We also saw cooperation in the Health Security Committee. So these were the elements that were already in place of the health security framework that were in place when COVID hit. We have a Health Security Committee that's made up of member states, health ministers and senior officials. They made use of the joint procurement agreement to start purchasing vaccines collectively. And we saw some pretty good sharing of information, best practice, who was planning to bring in what intervention when. There remain some problems with coordinating, particularly bans on travel or restrictions on travel and free movement of people. That's still being done even now without, from what I can see, good coordination and letting other countries and other member states know before these things are brought in. So there remain some difficulties there, but the structures are in place theoretically to be used for those things to be coordinated in a more constructive manner. We reached a point in April, May of 2020, where both the French and the German governments were calling for stronger treaty-based powers for health in the EU, which has never happened before. I don't think I'm alone in saying that there was nobody on an academic perspective that expected a treaty change in favour of health in 2019 anytime soon. But that was what was being called for in April, May. That was followed by the Parliament, who were in support of that. Quite predictably, that disappeared just because of the risks that come with opening the treaties up altogether. Politically, this would be tricky. Those calls disappeared, but what replaced them or what followed them was a commission that was able to really harness that political support and interest in health to put forward the EU for Health proposal with the budget that it had and to adopt the health union packages. So there's from what was a really disparate and tricky beginning, there was a real move to cooperation and momentum going through the latter half of 2020, I would argue. In which case I will finish up by just saying a bit about where I think this is headed. So I'll start just with a couple of thoughts on the specific parts of the health union that I introduced, and just a couple that I think are particularly interesting. The ECDC's role extension is not a small one into risk management, and it follows what's been written about elsewhere as a sort of informal Europeanisation of communicable diseases. It turns that into a much more formal Europeanisation of communicable disease policy. So that one's definitely integrative in nature and takes what was a previously not especially well governed at European level area and makes it something much more coherent and cohesive. Within the cross-border threats decision, I mentioned the stronger EU intervention and the public health emergencies. There's an element of being careful what you wish for here, I think, because the WHO gets itself into an awful lot of hot water on the declaration of public health emergencies of international concern. Now, what the EU will have is not quite the same right and responsibility in international legal terms, but it will almost certainly come with a similar level of political scrutiny. Did they call the public health emergency early enough? Could they have called it earlier? Did they call it too early and it was unnecessary and therefore created a lot of economic problems, political problems around the edges? It's a role and a responsibility that they will need to treat very carefully, and how it will come to be operated is still under negotiation. That I think is a large part of the reason that the cross-border threats decision is the one that's furthest behind in the legislative process, that's still undergoing negotiation and several revised versions of the text, and we're still not quite at the end of that process yet. For the EMA, the critical thing to watch there will be whether this regulation allows us to do something that we weren't able to do under the medical devices regulation. So when the new medical devices regulation was adopted in 2017, there was a discussion about giving the EMA a greater role and moving medical devices regulation towards a similar approach to that's used in medicines, in pharmaceuticals, and it was deemed politically infeasible. Yet it's now happening, but only within the confines of an emergency situation. There, I think there's real potential for spillover for us to see the same regulatory approach taken to medical devices that there was in medicines before. But again, we'll have to wait and see. Thinking a bit more broadly then finally, and how the health union feeds into wider health policy and what we might see elsewhere, I think there are a few issues here. The first is whether the EHU will move EU health policy any further than simply an extension of its crisis response capacities. Can it break free of this emergency framing to be more about strengthening health systems, improving prevention and promotion, and generally referring to public health systems? Those who work in public health are well aware that pandemics are exacerbated by, nay, perhaps even caused by, weakness in public health systems at a much more fundamental level. But there's not so much of that in the proposals that have so far been put forward. The issue is really going to be whether emergency preparedness and response is tackled as something holistic about the health of societies as a whole, about wider prevention activities, about access to health services, about healthy living environments, about green transport and air quality and good quality food, and all of these other, whether we can tie it into this much wider health agenda and move it beyond simply, do we have a stockpile of medicines and can we jointly procure vaccines? If it remains as a crisis-focused package and the role and powers of the EU remain focused on crisis and emergency, then it's unlikely to alter health policy much more widely. And sadly, what would improve the health of Europeans is if we can make it a much more holistic endeavour that increases the ability of the EU to more directly and deliberately influence health in a positive way. The second point is about whether it can feed into a clearer and a more deliberate role for the EU as a global health actor. The EU doesn't really have a global health policy. There were a set of council conclusions on the EU in global health in 2010, and they disappeared quietly into the night, largely in the midst of the economic crisis. It just, things overwhelmed and not much momentum was ever attached to it. And the sense within the literature is that the EU doesn't really have a deliberate global health policy. It has a very important non-deliberate indirect global health policy in that lots of what it does affects health in third countries, not least trade in pharmaceuticals, just to take a really obvious example. But much of that is not structured by a clear set of objectives and priorities that have been adopted by all of the member states. Whether, again, in a similar way to spilling over into prevention and wider public health, whether the EHU can spill over into more of a global health role, that's another angle. Things like the HERA have already been criticised for not including that angle particularly visibly. The EU's participation in COVAX and things like this has been fine, but not really any better than any other country. So there is a slight window here to try and build in a bit more of a global health facing role. And the final point would be about the Recovery and Resilience Facility. So this is a whole other half an hour lecture, but there are plenty of space within there for investment in health systems, as you would expect. Interestingly, the early, and I haven't done a lot of work on the plans as they finally come out, but the early plans that were being submitted under the RRF, so where member states were requesting funds to invest and reform at national level, the early plans were not as focused on COVID as certainly as I expected, they were much more focused on building up national health systems more holistically, and those plans were being approved. It wasn't all about focusing on communicable disease capacity and response. A lot of it was about not necessarily hospital building, but investment into much wider healthcare sector issues, whether that was health professionals, whether it was universal access to care, some things around, I saw examples around building new research laboratories and investing in domestic production of medical countermeasures and things. If the RRF can be used in that holistic way to fund better national investment in health systems widely, as opposed to this narrow focus on emergencies and crisis, then again, that might be a tool that supports an improvement of the health situation across Europe. The other thing to bear in mind there is that it's temporary and it's being integrated with the European semester. So that will require, if we are to achieve that outcome, that's going to require good investment and following up on that investment, but then also coherence in what the semester is asking for from countries and their fiscal policies as we roll forward. There would be no point in having lots of investments under the RRF now and then later the semester issuing a bunch of recommendations that ask member states to stop spending so much on X, Y, or Z thing that they put in place under the RRF. So there's going to need to be some real concentration on coherence between those two things as they roll forward. So that's my whistle-stop tour through what I think has happened to the European Health Union since November 2020. Thanks kindly for your attention, and I'll look forward to whatever questions are springing up in the chat box.
All right, thanks very much, Ellie. I thought that was a brilliant presentation.
I'd just like to thank you once again for joining us, and hopefully we will have you back in the not too distant future and face-to-face. I'd like to thank everybody for joining me today, and I'd also like to thank the director, Professor Dimitris Papadimitriou, for chairing the Q&A. It's always a pleasure to see him and also to work with him. Our next Jean Monnet Centre seminar will take place on the 23rd of February. We will be talking about the Ukraine crisis, a problem of trust, with Professor James Hughes from the LSE. So please keep your eye on all of our social media and promotion sites for all of that, and make sure you sign up. That's 3 o'clock. So enjoy the rest of your afternoon, and we hope to see you in 2 weeks' time. And many thanks again as well to Dr. Eleanor Brooks. Thank you.
Thanks.
Bye.
Thanks for having me.